Good Monday morning, everyone. It is February 7th. Welcome into the Morning Medical Update. Thank you so much for joining us here on Facebook and on YouTube. Coming up this morning, we have showed you for the past month or so how busy our ER has been with this Omicron surge, and it remains that way to this day. We aren't out of the woods just yet. Dr. Ken Marshall from our emergency medical department joins us to talk when you should come to the ER, as waiting rooms and beds are still very full. Also, Tiffany Clark, a nurse in the department, will also join us to let us know what to expect as overburdened healthcare workers try to help everyone get the medical care that they need, and her concerns as the ER remains a busy and exhausting place to work right now. Also in news this morning, the Jackson County Legislature is meeting to discuss if to implement a mask mandate for districts like Blue Springs and Oak Grove. Several districts across Jackson County have already put a mandate in place, including Grandview, Lee Summit, Raytown, and also Kansas City. In Douglas County this morning, commissioners will discuss requiring people who attend indoor events of 500 people or more to mask up. The hearing is set for Wednesday. If approved, the mask order would begin Thursday and run through March 9th. So please make sure you get your questions sent into us on YouTube and Facebook. Also email them to the Medical News Network. You can find those right there on your screen. Now, let's get to our COVID count and to Dr. Dana Hawkinson, who's joining us this morning. Good morning to you.
Yeah, hi. Yeah, hi. I think it'll be a good show. You know, our guest today, we know that emergency departments have really been the tip of the spear since the pandemic began. And Dr. Marshall and Dr. Allen, Dr. Cannon, all of their colleagues in the emergency department, and Tiffany and all of her colleagues, really all of the people who are providing support there have just done a great job and put themselves in harm's way. Right now, the cases, overall, the trend continues to go down of active infections in the hospital, and that is a good thing if you look over the past 7 days. Currently, we have 78 active infections, with 20 in the ICU, 11 on the ventilator, 93 in that recovery period, a total of 171 patients in the hospital. But again, the overall number of active infections has gone down considerably in the last 7 to 10 days, which is a good thing. Unfortunately, we have also continued to have deaths, and over the weekend we had 8 deaths, 3 on Friday, 2 on Saturday, and then 3 in the last 24 hours. And if you remember, hospitalizations follow infection by about 7 to 10 days, and then therefore also deaths tend to follow hospitalizations by 7, 10, 14 days. And so we are still seeing that effect of those great number of hospitalizations that we've been dealing with for the past several weeks. But hopefully, as we get less new infections in the hospital, overall our deaths will decrease as well.
We look forward to seeing that number go down. Dr. Hawkinson, thanks for that. While it appears fewer people are contracting the Omicron variant, patients needing emergency care are still up. Many waiting hours to see a doctor as overworked staff try to treat everyone who shows up at their doors. Here is a look at a typical night inside the ER.
There's been tons of people in the waiting room every single night. There's about 20 people in the waiting room.
And for some of those patients, it can seem like an eternity to get the care they need as they arrive at the emergency department.
Yeah, we're seeing very sick COVID patients, but also very sick non-COVID patients.
Dr. John Horkey knows he may not get a break on this day as the number of patients grows by the hour.
Correct, yeah. Did COVID come back?
COVID negative, yeah.
COVID negative.
Well, they have to wait for hours and hours and hours, and what I do wish is that we don't have such a thing, but unfortunately it's the truth.
Caleb Grott is one of the emergency department technicians here at the University of Kansas Health System.
There's a lot of demands that are met on us. Specifically, we're just expected to be in so many different places at once, and our role is to kind of gauge what is priority over another.
It's not just the doctors being kept busy. Nurses are feeling the strain, and they're overworked too.
We still are seeing all of our typical patients, like patients with cancer, and then also COVID patients. So it's been very busy, but luckily we have a great team here, and we've been able to rely on each other.
Emergency department, this is Stacy.
But even with a full emergency department, Grott says,
if you're having a real emergency, do not shy away. It's something that you don't want to toy with.
Let's turn to our guests now, Dr. Ken Marshall and Nurse Tiffany Clark, both from our emergency department. How are you both doing today?
Doing great.
Well, good to have you both. Thank you so much for being with us on this Monday. Dr. Marshall, I want to start with you because certainly seeing is believing. I just want to kind of, we saw this video, but take us inside a day or a night shift inside the ER right now.
Sure. It's been, incredibly busy, as you could see there from those clips. Our team has been through kind of a gauntlet for the last 2 years, and it's always a fun and interesting day in the emergency room because you have a constant stream of patients that have a variety of problems. COVID has added just an extra layer of complexity from a mental point of view, and also kind of bringing an extra load of patients on top of the usual patient load that we're already dealing with, strokes and heart attacks.
Well, and I think the average person, when they think of life down in the ER, we see it depicted in ways of everybody's hopping and moving, and it's, everybody's on their toes, and it's fast paced. But Tiffany, just jump in on that. I mean, how much does COVID play a part in what you're feeling on a day to day and the stress it's putting on you long term, 2 years in?
So, like I've said before, it's already a very high stress situation. We have very critical patients and very complex patients, and so you add COVID to it, it just makes things a little bit more complicated. And so things that would make that complicated is, having to not allow visitors in the emergency room, and so that family or friend support's not there for that patient, so they rely on the staff to play that part. Trying to have space for patients, you have to make sure that you follow isolation rules, and that can increase the time it takes to get in and out of a room. So we have to wait for COVID testing for patients who come in before they can go to certain parts of the hospital to get treatments that they need. We have to make sure that we get that COVID test back before we can continue on with that. And so COVID just kind of complicates things a little bit.
Complicates things, yeah. Correct. That's a good way of putting it. Do you still have people walking through the door wanting COVID tests and,
yes.
and like what you saw a couple of years ago? What's that look like? Absolutely. How is it different or the same?
I mean, it's kind of the same in a way. So we'll still have the people who will come in. They are not critical at that time, but we're that resource for the community. They tend to come to us for all different kinds of reasons, and it's no different from if they feel like they have COVID symptoms and they are not really sure where else to go to get a test or to get help, and so they'll come to us for that help. So.
Which you're glad, but again, it complicates things.
I'm glad we want, our doors are always open to the community, want them to come and seek our care, but it definitely makes the waiting room more crowded, and when you come in for a COVID test, you're going to wait many hours because, our higher acuity patients are going to go back first. We have to make sure that the sick patients are seen first.
So I want to ask you, because we're certainly not out of the woods, but that brings me to my next question, Dr. Marshall, is when should someone come to the ER? Help us kind of determine if we're feeling this, go here. If we're feeling this, wait, or come in immediately.
Right, yeah, and one thing is that COVID really hasn't changed that basic answer to that question, which is the ER really is ideally set up for people who are having life or limb threatening emergencies. So if you think you're having a stroke, you're having sudden loss of vision, loss of the ability to move part of your body, or loss of ability to speak, if you're having severe chest pains, trouble breathing, if you're having seizures that aren't stopping, if you're having a severe allergic reaction, or if you're having an obviously broken bone that's displaced, all those things are reason to come into the emergency room. There's other resources like urgent care centers that if you have a minor cut, if you just have the sniffles, if you have what you think may be like a urinary tract infection that is not making you systemically ill, there are other resources for that. And often our urgent care centers are really good about it. If they feel like they can't handle it, they'll send you to us if you're experiencing a more minor problem.
Sure.
If you have COVID specifically, mostly what we're worrying about, you're going to feel bad if you have COVID there. That's just the way it's going to be. What we worry about is if you're having progressive worsening shortness of breath, if you've already been diagnosed with COVID, that's when you might want to go ahead and seek care in the emergency department.
Well, and Tiffany kind of mentioned this. It becomes, the ER is that place that, again, the doors are always open. It becomes that catch-all, that safety net where we feel like we can always walk through the door and we're going to get care. You're going to experience wait times. We'll talk about that. But I just want to know what do you want people to know about when they come in? What's it going to be like for them to really think through the process of what am I experiencing? Can it wait? What is an experience from a patient perspective going to be like in the ER as it stands today?
Right. Well, I think the first thing that people sometimes that causes a little bit of confusion is they come into the emergency room, and obviously everyone wants to be seen as soon as possible. I think the first thing that would be helpful for patients to understand is the very first person that they're going to interact with is going to be our triage nurse. And our triage nurse is someone who is a nurse who's had a significant amount of emergency medicine experience and actually has to have enough experience to be trained specifically to do a triage assessment. And that's a data-driven, well-researched process by which the triage nurse uses the patient's presentation, the chief complaint, what they are visiting us for, and then uses their vital signs and kind of integrates all that information to try to come up with basically like a rank order of how soon they need to be seen. On top of that, sometimes patients don't understand why other people seem to be jumping the line.
That was my next question.
Yeah, and again, Tiffany's actually a triage nurse, so she can probably answer these questions even better than I can. But sometimes patients, if they come in and they look like they're having symptoms of an acute stroke to the triage nurse or a heart attack, those patients, we know those are time-critical diagnosis. That's a special term within emergency medicine. That means every second counts for that patient, and it's known. And we actually are held to regulatory standards to make sure that those kind of patients get brought back as soon as possible. And so that's another thing that you'll experience. Not only are you being seen by an expert nurse who is doing an evaluation based on this data-driven process, there may be some patients that are getting ahead of you, even if you're fairly ill and need to be seen quickly, just because for those patients, every second counts.
So Tiffany, frustrated patients?
Yes.
Tell me about
absolutely.
that. Tell me about some of your long wait times.
So, obviously we have patients who will wait for hours in the waiting room, and, they don't understand. So, an outsider looking in, they see that they've been there for 4 hours, and someone who just walked in the door will go back right away. And so, they just don't understand the process. And so we really have to make sure that the sickest patients, the ones that have time-sensitive interventions that need to be done, get back first. And so it is really hard to explain that to them. But if you do see that, just know that, the nurse, the triage nurse at the front door is doing everything they can to get you back, to get you seen. And so we do have to assign an acuity level, and that, like Dr. Marshall said, it's based on your presentation, vital signs, what kind of interventions you need. And some people do not need time-sensitive interventions, although they're uncomfortable and they're in pain. The emergency room is not a comfortable place to be, especially if you're not feeling well. But we do have to get the sickest patients back first. Resources are limited, staffing's limited, rooms are limited. And sometimes you really do have to decide who's going to get that last room. And it can be a very stressful situation. As a nurse, you want to help everyone. You want everyone to be cared for. I don't want anyone to be in pain or to be uncomfortable. But I really do not want the severely sick patients wait in longer. So when the waiting room gets really crowded, it just makes things a little bit more complicated.
And just like we see fatigue among staff and healthcare workers, there's certainly fatigue among the people. People who walk it through the door, they're tired of it. They want to get life back to normal. So their ability to wait is waned as well. What are your biggest fears? I want to ask both of you. Dr. Marshall, I'll start with you. Biggest fears we're about to enter into, if not, we are at the entering into the 3-year mark of this pandemic. What concerns you based on what you saw at the beginning to where we are today, and what lies down the road?
That's a great question. I think, we know that there's been a little bit of mistrust of the healthcare infrastructure more generally, and we sometimes see that reflected. Waiting in triage has always been an uncomfortable place for patients. They're nervous. Sometimes they're in, pretty severe discomfort. And so there's always been a little bit of tension where people are really wanting to get back, and it's totally understandable. We all have deep sympathy for patients in that position. Now we see kind of layered onto that sometimes a little bit of suspicion, I think, sometimes of our staff. And these are our triage nurses in particular, because they've been here. If you see a triage nurse, they've probably been here during the duration of the pandemic. Mm-hmm. They've seen the worst of the worst. These are nurses that are extremely seasoned and have been doing, the word hero is probably overused, but they have been doing heroic work for 3 years now. And so to have those people sometimes treated with a little bit of suspicion or disrespect is very difficult, because those people of all have just really earned their stripes and have put in the time. So I think coming off of that, I really hope that we can continue to see patients appreciating the nurses for the work that they do.
We can't continue to share that message enough. I really like this conversation because I feel like it's a refresher of what our emergency rooms are used for, and to help people understand, yes, doors are always open and you're going to get the care you need. You're just going to maybe have to wait for it. So it's just a good reminder of that. What are you most concerned about?
I am very concerned about just the burnout. This is something that we've been dealing with for quite a long time, and so our nurses have been there working the front line, and I do get concerned about staff fatigue. And I, again, as a nurse, you want to be able to care for everyone to the best of your abilities, and sometimes you feel like you don't have all the resources to take care of everyone, and so having to make that decision about who does go back first, it can be very stressful sometimes. And so I just want to let everybody know that we have your best interest in mind. We're going to take care of you to the best of our ability. We do care about you. You are going to have to wait a little bit longer. We understand that you're tired and you're sick and you're afraid, but just a little kindness and understanding goes a long way. We are working as fast as we possibly can. There's nobody behind the scenes that are sitting around not doing the best that we can. We're definitely working as fast as we can, as safe as we can to get you back, to get you seen. So when you walk in the front door and you see that triage nurse sitting there, just know that they've been working extremely hard and they have your best interest in mind.
All of our guests that were on last week, I think their final thought was, be nice to your nurses, be kind to your healthcare workers. Just that good reminder that they're not back to normal. Things aren't back to normal,
Right.
and they're at their limits. And I want to get to some community questions because we've got some good ones specifically for our guests today. Okay, so Wendy has a question. Burnout is real. It's real probably in every profession on some level, but in healthcare, I mean, there's no comparison. What do we know are we doing here at the health system to just help with burnout? We hear about ways to kind of ease the stress, but anything you're hearing and on how we're trying to help people find some relief?
There's lots of resources for our staff members. We have opportunities if we need to seek out someone to talk to about our fatigue or so our mental health is taken care of. We get fed really well. We often will have lunches provided for us, and a way to, a healthcare provider's heart is definitely to make sure we're well fed. That definitely keeps us going. Just the team itself, this pandemic has really brought us all together. I feel like there's a lot of collaborative work going on. I feel like the physicians and the nurses and RTs, pharmacists, we're all coming together, one big team. We're all in there together on the front line, working really well with each other. We all understand what the other one's going through, and so I think just having this amazing team is really helping with the burnout.
Do you ever get used to burnout? How do you find that extra bit to just push a little bit harder and a little bit more? And I think this is why they are called heroes, because they just when you think they've had enough, they just keep going. They keep showing up for their shifts and giving a little bit more. But do you get used to this? Do you get used to working under these conditions?
I think you just get conditioned. You're tired, you're hungry, you're burned out, but you care more about your patients than you do yourself. And so you show up every day because you know that you can make an impact on someone's life. And we are saving people's lives every day, and so we'll put what we're feeling aside because we have a job to do. And when you're in the healthcare profession, that's what you care about most is the well-being of our patients, and that's way more important than the burnout that you feel that overcomes any tiredness that you feel or stress that you feel. So you always put the patient's needs first.
That's why you do what you do and the rest of us do not. So
Yep.
Special people. Janet wants to know, does the ER separate possible COVID patients from other patients in the waiting rooms? What does that look like in a time of COVID? How do we organize everyone and keep everyone safe?
We try our absolute best to do that. We make sure that everyone's wearing a mask. We do have a area in the emergency room where we try to keep our COVID patients separated, but obviously with crowding, it's very hard. So our strict visitor policy has really helped us with that to try to help social distance people. We've spaced chairs out. We walk around and remind people to keep their mask on. We have sanitation stations where they can sanitize their hands. We have people going around cleaning chairs, and so we try our best to keep them separated, but it's almost impossible when the volume's up pretty high.
All right, I have a question from Jean. What is your opinion from a healthcare standpoint of the proposed Florida law requiring visitors to be allowed to see sick and dying COVID patients, or to allow people to come in and see sick and dying COVID patients? Just your opinion. I know that's not where you work, but Dr. Hawkinson, jump in as well. Just want your all's opinion on what that could mean, what your thoughts are, what that means to a health system.
Yeah, I don't know the details of that law, so a lot of it would depend on exactly the details. I think it's difficult, with legislation to make sure that we're really getting it right. Sometimes it's a little bit better to let healthcare institutions try to calibrate what they're seeing in the community, what they're seeing in terms of spread and death rates. That being said, none of us like the situation where you have a patient who's critically ill, whether it's with COVID or anything else, not able to see their loved ones. That's been one of the most painful parts of the pandemic, I think, to all of our healthcare professionals. And so while the intent of the law sounds good, it's hard to know whether or not it's a good idea without looking at the legislation.
Okay, I promised no more political questions.
Yeah.
We usually get one a day, but Dr. Hawkinson,
Yeah.
anything to add?
Yeah, I don't think it has to be political. I think it's just a matter of you have somebody, just like Dr. Marshall said, a loved one who is suffering critical illness and near death. I think it is important. We have some very good patient advocates here who do advocate for that. And I think we do it, and we can do it safely to get you in to see your loved one. And again, the most important part here is that everybody is going to be wearing a mask to do that, because we know that spread, even if you aren't having symptoms, is so extremely common. So we have great patient advocates here, and we do actually work on a case-by-case basis if we think there is somebody that is specifically critically ill with COVID. Now, there are quite a few other instances when people are critically ill or near death or on hospice, what have you, that we allow them to come in. So, we do have those processes in place, visitor policies, things like that, and just excellent patient advocates here as well.
And Dr. Hawkinson, don't you think it's changed certainly from the beginning
Yeah.
of the pandemic and what we've learned now? And we have a vaccine, so there's lots of other variables.
I think that's the great points you make there, Jessica. We do have the education, we do have the data, we understand how it's spread and how to protect people, and I think all of those things play into that.
Rebecca wants to know, what's the difference between an ER, like here at our place, or a community ER hospital? Rebecca thinks those seem to be a little less busy, but what kind of cases are they handling? And then a similar question about urgent care. So when to go to a community ER, an urgent care, or come here?
Right.
Help us understand that.
Yeah, that's a great question. And there is a big difference, between urgent care and an ER, right? That's the first distinction. Urgent cares are really well suited to take care of some of the more minor problems that are something that where your life or limbs are not at risk. Minor cuts, sprains, if you have maybe COVID but are not severe, those sort of things. An emergency department, as we talked about before, is if you feel like you have the risk of life or limb threat, or seizures that aren't getting better, things like that. Now, that being said, most community ERs that you see should be able to cover a broad majority of emergency medical conditions. But there's also a big difference between a community ER and a place like KU, right? We're a stroke center, we're a STEMI center, we're a level 1 trauma center. And so we have capabilities that the community ERs won't have, in addition to the fact that we are connected with all of our tertiary and specialty care centers. So if you're getting cancer care here, if you've had a transplant here, we have a lot more capabilities than a community ER can have, just by virtue of the fact that some of those ERs don't even have inpatient beds. They don't have surgical specialists. They don't have cardiologists that are on hand if you need an extra level of care. So that's kind of the difference. There's sort of almost like a three-part division in that respect.
Okay, that makes sense. Dr. Hawkinson, Ashley is curious with infants, because they're not vaccinated. If you think they need medical attention, how do you know that and when to bring them in? Should they just wait it out? I know you are not a pediatrician, but I just have to ask for Ashley. She's one of our viewers, and I think she's just curious. And if there's monoclonal antibody treatments for infants or young children, what do you know?
Yeah, so a lot of questions there. I am not a pediatrician nor a neonatologist, but certainly
Take a crack at it.
I am a parent, and I do know that kids are pretty tough, but for instance, falling off the bed, they just seem to get up and bounce right up and have no problems. But we're not talking about that. We are talking about if your child is ill, either with COVID or something else. I know that can be very scary, and it's very difficult to really make that assessment, especially as a new parent or as a non-medical professional or somebody who doesn't really see pediatrics. I think you really have to judge that particular instance with that particular child on a case-by-case basis. And I think Dr. Marshall or Tiffany may have a little bit more insight because they probably see pediatrics. But it's really just understanding what the situation is, what those symptoms are, your child, your particular child's medical needs to really assess exactly when do I seek medical attention. And I think it can be very difficult. And I think we would always say probably err on the side of caution for that, because you want to make sure you get that child to medical care early enough. But just understanding those specifics, and maybe Dr. Marshall has some more comments about that.
Yeah, in general, one of the things that's really fantastic about almost every pediatric practice in the country is their nurse triage line. And often you have a relationship established with a pediatrician. They can see, the nurse triage line can even pull up information about your child if necessary, and really help you provide the guidance of when you can seek care. And like Dr. Hawkinson said, if you're concerned, sometimes caution is kind of the best answer.
Well, let's be honest. If you're a parent with a young kid, you're probably concerned about all sorts of things. Right. It's not easy to decide, when to make a move and go in. Dr. Hawkinson, you have something to add?
One of the last questions was about monoclonal antibody therapy, and I think all of the EU8 or authorized, emergency use authorized treatments right now are really for those patients that are 12 and over, and I believe it's like 85 pounds and over. So as of right now, I don't believe there's any treatments available for those young children.
All right, Isaac wants to know how much ER overload is due to trauma from car crashes, recent snowstorms. It's been pretty somewhat mild this year, but in the past, if you compare the last couple of years, this year, how much does that play a part?
In terms of overcrowding, traumas really don't create a great deal of volume. Now, you might, if you've been a patient that's waited in our waiting room, sometimes that might be surprising, because sometimes traumas tend to come in bunches, and there are times when we have a few traumas come right in a row. And so on those rare instances, it might seem to a patient like traumas are creating a lot of crowding. But in general, our trauma volume, if you look at it over the course of a year, our major trauma activations are maybe on the order of 3 a day. And so it doesn't really contribute when you consider that we actually see 170, 175 patients a day in the ER. Not a big component. And also this last snowstorm, we really didn't see very much snow-related injuries, which we sometimes do, but not that much this last week.
Tiffany, what's your message to people? We've talked about it a couple of times on this show, just to be careful out there. During a time when, again, we're talking about lack of beds, overworked staff, long wait times, about just being really careful. Don't do stupid things. Don't be on the roads when it's not necessary. What's your message to people?
My message is, wear your seatbelt, take care of yourself, try to be as healthy as you possibly can, try to seek help through your primary care doctor. If you're starting to feel sick, try to take care of it right away. Don't wait to when you become more severe. And just be careful. Make good decisions the best that you can. Clearly we're always open. Our doors are open to you. We want to take care of you. But, things are just a little more complicated now. And so you might have to wait a little bit longer if you wipe out on the bird while texting.
Make good decisions. I think, right? Yeah. Make good decisions. I think we've all heard our mothers say that before, right? Yeah. Peggy is asking, Dr. Hawkinson, why are there so many vaccinated patients in the hospital right now?
Yeah. So I think I think this does go back, and this may be confusing, and I understand how it is and why it is, because when vaccines came out, we saw they reduced your chance of getting infected, they reduced your chance of hospitalization, severe disease, but now we are further into that process since the vaccines were initially rolled out. We've seen other variants as well. And so really the vaccines now being, it's called up to date with vaccination rather than being fully vaccinated. Fully vaccinated, for those people that are not immunosuppressed, continues to be 2 doses, but then being up to date means that you've had that booster dose at least 5 months after those 2 doses of mRNA vaccines. So I can't understand how it is confusing. And really the best data right now coming out and supporting that is that you have the best protection when you are fully vaccinated, meaning you've had 2 doses of the mRNA, and then you've had your booster. So that's really 3 doses. And if you're immunosuppressed, it is 4 doses, because you have 3 of that primary series, and then you have that booster dose, which is your 4th dose. But what we are seeing, and what we continue to see, is those people that have had 3 doses really continue to be very well protected from hospitalization, severe disease, and death. And that has held true even through Omicron. We know Omicron can evade those antibodies that are created. But we know with that booster dose, you do develop some antibodies to Omicron even. But we know those T cell responses that really protect you against severe disease continue to hold true with those 3 doses. And what Dr. Marshall and I were just talking about when I came in was that it's those 3 exposures to spike. And there's a pretty good article, I think it's Nature Immunology or Nature Medicine, that really showed that 3 exposures to spike, whether that's through vaccination or vaccination plus infection, really offers very good protection against hospitalization, severe disease, and death. And so that is really holding true. What we are seeing now in the hospital, I think this is really true throughout the United States, is those people that have had 3 exposures, really, and vaccination is going to be the safest way. They are continuing to be protected from hospitalization. I think right now in our hospital, those people that are up to date with vaccination, meaning 2 doses of primary series and then that booster, we are seeing only 8%. So 91% of the people in the hospital with active infection are not up to date with their booster dose. And so hopefully that helps clarify a little bit with that question. But that's a very good question.
Marlene has a question for Tiffany. How do you handle angry patients? Do you ever fear for your safety? How do you manage that? Is that an issue, and has that grown over the last couple of years?
It has, again, because of all the extra stress that's going on in people's lives. This is a very stressful time. There's people who have lost their jobs, lost family members, and so they do come to us, and they're a lot more fearful. And so they can be quite anxious and angry when they first come in. And we just do our best to try to de-escalate the situation. First of all, we just try to let them know that we see them, we hear them, we understand that they're here to get help, and we want to help them. We try to make them as comfortable as we possibly can. You just have to be very empathetic the best that you can. You have to understand that this is coming from a place of fear and anxiety. I don't think people necessarily want to come in the door and treat us like that, but again, everybody processes their anxiety a little bit differently and their fear a little bit differently. A lot of people don't understand how the healthcare system works, and so it's a very confusing process. And they walk in and they see that the waiting room's really crowded, and they can see that they're going to have to wait a little bit, and that just makes them really stressed out. And so again, we just try to greet them with a smile, and we try to make them as comfortable as we possibly can. And sometimes it's just giving them warm blankets and listening to them, and just trying our best.
Something tells me if someone meets Tiffany at the door that you're very disarming and very kind.
We try our best.
How could they be mad at you? Oh my goodness. Dr. Marshall, just your insight. What do you see has gotten better, worse? Is it just all in a day? I know folks are trained here to handle these and de-escalate these type of situations, but your insight?
Yeah, I think COVID, for as much of a challenge as it's been in the emergency department, I think that we are working better as a team than we really ever have. The relationships that we've established, both with our inpatient hospitalist groups, our ICU teams, our respiratory therapists, it's really brought us together working so much more closely together. I feel like one of the silver linings of COVID is going to, at least at KU specifically, is that our integrated care is going to be much more advanced than it has been before. And in terms of our team specifically in the ED, I'm really looking forward to COVID being, kind of receding into the background, because I think we're really well set up to deliver better emergency care than we ever have, And you asked about what we're doing for burnout specifically. One of the most important things has been the camaraderie that we have as a team, whether it's having exercise competitions, independently, of course, but exercise competitions, our pharmacist group, for instance, has Pharmacy Fridays where they bring in candy for everyone. And it's just kind of little things like that where
Can I get it on that group?
Yeah, absolutely.
Okay.
We'll see you on Friday.
Okay.
And so it's really the camaraderie and the teamwork that we've really put in as a result of the extra work we've had to do the pandemic. I think it's going to set us up spectacularly.
That's
well.
exactly what I was going to say. It sounds so cliche, but aren't you just going to come out so much better? There's no way you're going to go through 2-3 years of this and not be better on the other side,
For
right?
Sure. Exactly.
Dr. Hawkinson, you're not a pediatrician nor an ER physician, but you do have some insight on this, please.
Yeah, I think Tiffany's answers were so apropos and insightful, and it's she talked about displacement. It's a lot of displacement of anger, and it comes in and it goes out to people you don't even know. And this is so common in the world today. Unfortunately, it's the climate that we live in. And I think the underwriting current there and creating that certainly has been the pandemic and COVID-19. And it's not just in the emergency department, but it's really anywhere you go. You can see evidence of it. It's at our stores. Airports, any place, it just is so common right now, unfortunately. And I think, we can get through it, but I think just as Tiffany said, I think it's important to try and remain calm and just de-escalate the situation and just make sure that everybody continues to act civil towards one another.
Good advice. Ivy wants to know, I've got a few questions for you, Dr. Hawkinson. Is there a recommended second booster for the general public? When's that happening? Is that happening? Get us up to date on that.
We know certainly in Israel, they are recommending a second booster. So that would be a 4th dose if you are not immunosuppressed. But I haven't seen any data on the importance of that. We know there is good data supporting the use of that 3rd dose, that 1 booster. So right now we are just continuing to wait for the data. We will continue to wait for the recommendations. More than likely, if that does come down, it will be safe. But just as we saw, those 3 doses of vaccine really do protect well. And I think the key component of that is that 5 or 6 months from that second dose to that booster dose. That is what really allows your immune system to continue to evolve. And then when you get that 3rd dose, that booster dose, that evolved immune process then is boosted by that. But right now, I don't believe there is any indication or recommendations for a 4th dose if you are not immunosuppressed here in the United States.
All right, Joe, I hope that answered your question too, because Doc Hawk, he was worried about his 90-year-old mother getting that 4th dose. She's already had the 3rd, so should she be okay as long as she's in pretty decent health?
So I think that is a good point. We know patients, especially that are older, say 60 and above or 65 and above, seem to have a more rapid waning or decrease in their immune function after vaccine. So if it does come out, if it's not for the general public, as we have seen in the past, initial recommendations probably will be for those people in those older age groups. Again, right now, no recommendation. Is it safe? Yeah, it is probably going to be safe. We know that these vaccines are extremely safe and the adverse events are extremely rare. So wait for that, and we'll just wait and see. Hopefully, there will be some information coming out as to whether you need it or not, and hopefully cases are going down overall, so exposure and risk for actually infection is going to be going down here in the next few weeks as well.
All right, couple more questions. Yeah. Pat and Angela, similar questions. Is COPD considered immunocompromised, and can you give some examples of what immunocompromised is, or maybe people at risk, which is, I think, what people mean by that?
Yeah, I think COPD would be more of a person at risk because it does affect your lungs. It is not considered immunocompromised. When we talk about immunocompromised, specifically that is going to be reductions in your immune response, whether that's because of drugs, such as immunosuppressive drugs if you've had a transplant, or if you have autoimmune disease that reduces your immune system, such as your T cell and B cell functioning, whether that's inborn or acquired immunodeficiencies, whether you were born with them because you just don't have a full functioning immune system, or things like people who have HIV, uncontrolled HIV or AIDS, or other, say, blood cancers. Those are really what we consider immunosuppressed states or causes for immunosuppression, rather than something like heart disease, obesity, COPD. Those are risk factors for severe disease, but those necessarily wouldn't be considered immunosuppressed.
But do high-risk people and immunosuppressed people, are they the same? Do they have the same are they on the same level when it comes to concerns? I think we have people.
I think it's different depending on what you're talking about. Are you talking about response to the vaccine? Certainly you are going to be higher risk if you are immunosuppressed, if you are on some of those immunosuppressive drugs for autoimmune disease, for cancer, what have you, as opposed to if you are not on those drugs. So I think it is different, and I think it depends on what you state. If you are talking about risk factors for progressing to severe disease, again, still different, but yes, both of those populations would be at risk for progressing to severe disease, just in a different manner. And that's why for those immunosuppressed patients who have some sort of error or inability to mount an adequate immune response, they are recommending 4 doses of vaccine, 3 primary doses, and then that booster dose. So there is a little bit difference there, but all of those populations are definitely at risk, more at risk of progressing to hospitalization and severe disease.
But you explained that well. That makes sense. Okay, last question is from Isaac, and it is to both of you. And it is a debate that people talk about a lot, and it's not something that we do here. But what are your thoughts on using vaccination status as a triage criteria? We know people have shown a lot of frustration. People aren't vaccinated. Why do they get treated first? Why over somebody who is vaccinated, who's maybe having a heart attack? Tell people what the deal is on that.
Yeah, that's a really interesting question, and maybe luckily it's not something that we have to think about too much in the emergency department. We see patients in the emergency department who are there because of choices that they've made that maybe were not the greatest choices, and we also see lots of patients that are there because of something that they had no control with whatsoever. And one of the things that you just simply have to learn early in your career in emergency medicine is that your job is not to kind of make moral judgments about how people have been living their lives. We treat people regardless of what brought them there, based on the severity of their disease. And so trying to set up a kind of triage system that integrates the health choices that they've made prior to arriving, whether it's because they've made poor dietary choices, maybe they've been drinking too much and then doing unusual things, drinking and riding a bird scooter. That's not a judgment that we can be in the business of making and trying to factor into our decision making. So while I understand the kind of impulse behind the question, factoring in somebody's vaccine status or whether they've been wearing a mask or whether they've been doing the right things is not something that we can do. What we do have to do is take that patient at face value and do our best for them to make sure that we're trying to correct whatever's going on with them.
Your job is not to judge. Tiffany, help us feel better about that. And for those people who do have that question or are frustrated, help put those frustrations to ease a little bit. Yeah, because I don't want to walk in and have you judging me on something either. And I don't think they do either.
Yeah, it's not based on judgments. Again, like Dr. Marshall said, when you walk in, you're presenting complaint. That's what we judge it based on. We judge on, who's the sickest and who needs to be seen first. And if you were to come in and you have a broken arm, say 2 people come in and you both have broken arms, we're not going to take the person who is making a really bad decision and broke their arm and make them wait, whereas the person who was safe and was making a good decision and they broke their arm and they get to go back first. That's just not how it happens. You both have broken arms and the most severe will go back first, and that's how we make all of our decisions. The choices that you make outside of the emergency room doesn't really come into play. As far as the vaccination, we do ask if you've had your vaccination because it's important for us to know, just to plan your care and also to maybe offer the opportunity for you to get the vaccination while you're there, but that isn't part of the decision.
And we don't want people to stay away from the ER because of their vaccination status, thinking they're not going to get the right care that they need.
You're going to get the care that all of our patients deserve, the best care, and so if you walk in our front door, that's what we're going to give you, is the best care that we can possibly give, no matter what.
Patients created equal. Dr. Hawkinson.
Yeah, I think those are all great points. And again, this isn't something new. Things have been happening since hospitals were around, and emergency departments were around forever. There are some things that people do that other people may find, immoral or not the best practices, like you said. Things like drug abuse or doing, like Tiffany said, just something that you shouldn't otherwise be doing. But there is no judgment. We take you as a whole person and compassion and going to treat you to make your quality of life better, to get you better, really no matter what that standard is that you are adhering to outside. I think that's the important thing to understand about the health system and really pretty much all medical providers is that you are coming in ill. We are going to try to make you better. We are not judging why or how that happened. The main goal is to get you feeling better.
All right, let's get to some final thoughts today. So glad you were with us on this Monday. Please come back. Dr. Marshall, let's start with you. Just some final thoughts.
Final thoughts are that while it's been difficult to take care of people and the coronavirus pandemic has made it a difficult place to work, kind of reaching back to the last question, it has honestly been a real pleasure, and I know it's been a pleasure for our own staff to take care of people whether they are vaccinated or not, And it's sometimes been an opportunity to start rebuilding bridges between ourselves as medical professionals in the community. If you've been someone who's been, kind of maybe a coronavirus doubter or a vaccine doubter, but nonetheless you are needing to come and seek our care, it's still our pleasure. We want to serve you regardless of who you are, whether or not you've been potentially suspicious of the medical profession in general. So I think that we're going to come out of this stronger, and we are ready to really rebuild trust and rebuild bridges to the community, no matter who you are.
Great message. I love that. Tiffany, final message for our viewers.
The same thing. You can trust. You can know that when you come in the front door at the emergency room, that we have your best interest in mind, and we're going to do everything in our power. Every resource that we have, we're going to use to get you better, get you what you need in order to walk out that door healthy again. And so you can trust that we always have your best interest in mind.
And thank you to both of you and all of your teams down there and all of your workers. We appreciate them so much. Dr. Hawkinson, final thoughts?
Yeah, I'm just going to piggyback and echo what our guests say. I don't think I could express it any more clearly than they did. So.
Good. So you're just going to steal their thoughts?
It's easy.
That's okay.
It's easy for a Monday.
It is. You're taking the easy way out. They had a great message to share. So thank you. I'll let you off the hook today because you'll be back tomorrow. Thank you all for being with us today. Don't forget you can catch our shows anytime on Facebook and on YouTube. Coming up tomorrow, slowly more children and teens are getting their COVID vaccine. More youth are heading back to play sports. But there is one thing parents are now seeing that's causing some big concern, and that's something we have talked about, myocarditis. It's inflammation that doctors say can weaken the heart. We're going to talk about that and the new guidelines for kids returning to sports after COVID. Now, earlier, we took you inside the emergency department during COVID, and as we leave you today, doctors and nurses throughout the whole hospital share the message that it is not over.
My name is Megan Pizzella. I'm a registered nurse and I work on Cambridge 8 ICU. I asked a few of my coworkers to describe what they're experiencing on the inside, and some of the words that they used were exhausting, depressing, inevitable, preventable, and emotionally depleting. And those are the things that we are seeing with this patient population. It's just very stressful on us.
I'm Audra Estes. I'm a registered nurse on an inpatient COVID unit at the health system. We have overcome incredible challenges, faced danger, and faced even secondary trauma as we have cared for these patients.
My name is Dr. Christopher Brown. I am an internal medicine physician here at the healthcare system. I function as a hospitalist, and my primary roles are to round and take care of multiple different type of patient populations. I've taken care of hundreds of different COVID patients. From my perspective, the patient could no longer see my face. The patient could no longer have family members present. I actually had a patient that said they don't necessarily remember me, but they remember my voice.
My name is Zara Mahmoud Jafari, and I am a clinical pharmacy manager for hematology, bone marrow transplant, and cellular therapies. Our patients are the most immunosuppressed in the entire health system. We have banded together in 2020, we banded together once again in 2021, and then now in the heat of this most recent surge, and more challenges than we've ever anticipated. Now with our own staff falling to COVID and having to work from home, we've really met each and every challenge with one another.
We have been working together as a team to provide excellent care for these patients. We have been having different nurses deployed to different areas who don't normally work there to deliver trays to our patients so they can eat. I have seen nurses in lab coats scrub and clean our floors for housekeeping. We are all just working together to get the work done as a team.
I am so grateful for my team. I am confident of how myself and my coworkers have stepped up every single day to care for this community, to serve it well.
For me, the COVID-19 pandemic has confirmed that we are flexible. I don't really care for the word resilient. My preferable word is the word perseverance, because despite the number of challenges that we've had with every year the pandemic has offered us, we have persevered above that.
I had one day where I had 3 people die before 9 a.m. before even having my coffee.
Honestly, what's happening on our units at this point is unsustainable for our staff.
And he's got his wedding ring and his watch and his hearing aids. We should just keep those with him, I think.
They expected to have so much life to live, but yet they're down here in the morgue. We have to take this serious. We have to know that life is very short.
One thing we know is that with this vaccine, the literature, the data, the information has made it very clear that it can level the playing field and lowers your ability to be hospitalized, have severe complications, and/or die. One thing that we can do as a people is figure out a way to just come together, remove ideologies, remove personal beliefs, and just realize, again, going back to the data, if we can just continue to just get people vaccinated, that would help the most.
It's such an interesting dichotomy to be working on this inpatient COVID unit and then to clock out and leave and go to my community where hardly anyone in the grocery store is wearing a mask. And what I would like to see in our communities is an increase of masking, testing, and vaccinations, because what we're seeing is largely preventable if we're implementing those resources.
Just knowing what we're going through is not our normal. Your support and honestly your prayers would be very beneficial for us as healthcare workers.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.